Good morning. It's a pleasure to be here today and talk about updates on supportive care and treatment of multiple myeloma. I'm Agnia Piener, Associate Professor at Rush University Medical Center. Multiple myeloma is not a curative disease. Once diagnosed, patients have to learn to live life with multiple myeloma. Therefore, supportive care is the key to quality of life of patients with multiple myeloma. And the complications that patients need to be supported through can be divided into those of the disease, complications of treatment, and also what I call complications of life. Patients truly need multidisciplinary support from hematologists, orthopedic surgeons, radiation oncologists, social workers and psychologists, as well as palliative care professionals to maintain quality of life through the treatment of multiple myeloma. There are multiple complications of the disease. Most importantly would be those of bone. Patients can develop very severe osteoporosis and lytic lesions that eventually can lead to pathologic fractures and pain, even cord compression. By nature of the disease, patients with multiple myeloma are immunocompromised and at higher risk of infections, and that risk of infection can be further increased with treatments for multiple myeloma. Some of the treatments can also cause unique side effects such as increased risk of deep vein thrombosis, infusion reactions, skin rash. And in the group of complications, I do include financial toxicity of therapies as well as adjustments of living with chronic disease and some of these patients living with chronic pain. So let's start talking about bone complications of multiple myeloma. Up to 90% of patients during the course of myeloma develop bone disease, which can present with skeletal events such as need for surgery due to pathologic fractures, need for radiation due to pain, even cord compression. The newest update in multiple myeloma bone modifying agents was the study that proved Denosumab to be non-inferior to Zoledronic acid. This study was published in 2018. Close to 2,000 patients were randomized to receive either Denosumab with placebo or Zoledronic acid with placebo on a standard monthly basis. And the primary endpoint was reached. It did prove that Denosumab was non-inferior to Zoledronic acid when it came to time to first on-study skeletal related event. The major difference between these two arms was in side effect profiles. Denosumab is a monoclonal antibody against rancor and therefore is not cleared by kidneys, rather by reticular endothelial system. It's not thought to be nephrotoxic, and that's what we saw in the study, that patients treated with Denosumab were less likely to have deterioration of kidney function. That was particularly true for patients with GFR of less than 60. There was increased risk of hypocalcemia in patients treated with Denosumab, so supplementation with calcium and vitamin D is very important. Osteonecrosis of the jaw was not statistically significantly different among these two arms. Before you start treatment with bone modifying agents, you may want to consider what is their kidney function, and perhaps patients with already impaired kidneys or those who have worsening kidney function while receiving bisphosphonates should rather be treated with Denosumab. You want to make sure that their vitamin D levels are repleted, since patients that are vitamin D deficient will be more likely to develop hypocalcemia. Dental exams are important in order to prevent osteonecrosis of the jaw, and certainly cost. Denosumab is much more expensive than Zoledronic acid. Now, while in the treatment, patients with bone modifying agents should have their kidney function monitored, dental exams to diagnose and prevent osteonecrosis of the jaw, and again, supplementation with calcium and vitamin D. One important thing to note about Denosumab is it can cause rebound osteopenia and fractures. Therefore, if you decide to discontinue Denosumab, you may want to consider giving a dose of bisphosphonates. So bisphosphonates, either before or after treatment with Denosumab, have been shown to decrease risk of subsequent rebound fractures in patients with osteoporosis. Osteonecrosis of the jaw is a very dramatic complication of both Denosumab and Zoledronic acid. The risk factors are poor dental hygiene, need for invasive dental procedures during the treatment, and also the duration of myeloma. So with a greater exposure to these drugs, longer duration of multiple myeloma, patients are more likely to develop osteonecrosis of the jaw. Can Denosumab be used in patients with end-stage renal disease? Patients with GFR of less than 30 were excluded from the phase 3 trial comparing Denosumab to Zoledronic acid. Zoledronic acid is not recommended in patients with GFR under 30. So it is a very pertinent question. Can Denosumab be used in those patients with unmet medical needs, those with very low GFR? Dr. Block has studied pharmacokinetics of Denosumab in patients with severely impaired kidneys, and it looked like they were quite comparable to pharmacokinetics in patients with less impaired kidney function. The major difference was the risk of hypocalcemia. Patients who have severe kidney impairment are more likely to develop hypocalcemia while on treatment with Denosumab. How much of bone-modifying agents patients with myeloma need is an answered and debated question. This study has looked into frequency of administration of Zoledronic acid compared monthly versus every 3 months of Zoledronic acid with patients with solid cancers with bone metastasis as well as multiple myeloma. Zoledronic acid, whether monthly or every 3 months, was continued for 2 years, and the primary endpoint of the study was proportion of patients with at least one skeletal related event during those 2 years. So both approaches seemed equally effective, and perhaps there was a slight decrease in osteonecrosis of the jaw or renal dysfunction in patients who received Zoledronic acid less frequently. Now, NCCN guidelines and ASCO guidelines recommend that bone-modifying agents should be started for all symptomatic patients who require systemic therapy, regardless whether they have lytic bone lesions or not. Bone-modifying agents are recommended up to 2 years, either monthly or every 3 months, and continuing bone-modifying agents after 2 years has to be based on clinical judgment. In patients with severe renal impairment, Zoledronic acid is not recommended. Patients with renal impairment should either receive adjusted dose Zoledronic acid, extended infusion Pamidronate, or Denosumab should be favored. There is a phase 2 trial ongoing specifically in patients with multiple myeloma and GFR less than 30, exploring safety and efficacy of Denosumab. I'd like to move to infectious complications of multiple myeloma. Just by the nature of myeloma, patients are immunocompromised. They have 15-fold increased risk of shingles reactivation. That risk is further amplified by treatment with proteasome inhibitors, monoclonal antibodies, as well as after autologous stem cell transplant. And therefore, antiviral prophylaxis is recommended during therapy as well as 6 months afterwards. Patients have impaired response to vaccines. Only 20% of patients with multiple myeloma will achieve protective antibody titers to flu vaccine, and only 1/3 to streptococcal vaccine. It is estimated that up to 20% of deaths in the first year after diagnosis of multiple myeloma can be attributed to infection. So the colleagues in United Kingdom wanted to investigate whether prophylaxis with levofloxacin would help to prevent febrile episodes and death from all causes in patients with newly diagnosed multiple myeloma. Patients were randomized to receive either levofloxacin at 500 milligrams daily for 12 weeks or placebo, and they were assessed for febrile episodes and death of all causes within those 12 weeks of therapy. This approach proved to be effective. The risk of febrile episodes and death was reduced with a hazard ratio of 0.66. Importantly, there was no associated increased risk of healthcare infections or carriage of nosocomial pathogens with prophylactic levofloxacin, and patients were allowed to receive Bactrim for PJP prophylaxis, and that too had an additive effect to Levaquin. Recombinant Zoster vaccine was studied in patients after autologous stem cell transplant. In this phase 3 trial, half of the patients had multiple myeloma. They were allowed to receive acyclovir prophylaxis for the first 6 months after transplant, and they received shingles vaccine, recombinant Zoster vaccine, within 2 to 3 months after transplant, followed by second dose given 1 to 2 months later. The incidence of shingles within 1 to 21 months after second dose was decreased, with efficacy of the vaccine of 68%. So that is something that needs to be considered in patients with multiple myeloma. I do explain to my patients that shingles vaccine does not eliminate risk of shingles, but decrease it significantly. And they may still need acyclovir prophylaxis while on therapy with proteasome inhibitors, monoclonal antibodies, or if they have personal history of shingles. NCCN guidelines recommend acyclovir or valcyclovir prophylaxis for all patients who receive treatment with proteasome inhibitors, Daratumumab or Denosumab, as well as 3 to 6 months beyond therapy. Levaquin should be considered for newly diagnosed patients for short-term prophylaxis. In a few patients that could be getting high-dose dexamethasone, PCP, shingles, and antifungal prophylaxis is also recommended. Intravenous immunoglobulins should be considered for patients with recurrent life-threatening infections, and pneumococcal vaccine as well as flu vaccine is recommended despite low response rates. And with that, I'd like to turn to supportive care during the treatment of multiple myeloma. My colleagues and I had published extensive review article on managing various toxicities with triplet regimens that include novel agents and monoclonal antibodies. It can be particularly challenging to manage side effects with triplet regimens because there are some toxicities that are overlapping. So the article provides practical considerations as well as tables and figures to get your answers on a go on how to manage the side effects. I will focus on a few that have updates, and I would like to start with infusion reactions due to Daratumumab. They are unique in terms that they mostly present with upper respiratory airway. Patients with asthma and COPD can have a flare of reactive airway disease. Patients with severe COPD or asthma actually were excluded from clinical trials. And those who have less severe disease should be optimized with long-acting bronchodilators and inhaled steroids. They should be encouraged to use short-acting rescue inhalers if they develop shortness of breath during or after treatment. Majority of the reactions to Daratumumab infusion happen with the first infusion. They can be delayed, therefore steroids should be given not only prior, but also after the infusion as well as next day. And montelukast has been shown to decrease risk of infusion reaction by 1/3. So certainly something to consider in patients starting treatment with Daratumumab. Just recently in May, subcutaneous Daratumumab in combination with hyaluronidase was approved by FDA based on phase 3 trial that proved non-inferiority when it comes to response rates and trough concentration. In this study, not only effectiveness and pharmacokinetics were comparable among the two, but more importantly, there was a decrease in infusion reaction rates. 34% of patients had infusion reaction in intravenous Daratumumab group, while only 13% of patients had infusion reaction in subcutaneous Daratumumab group. It is important to know that median time to onset of infusion reaction after subcutaneous Daratumumab was about 3 hours. So even though subcutaneous injection is short and quick, patients should be observed after at least first injection for about 3 hours in the clinic. Infusion reaction is more common and usually presents sooner within an hour of administration of intravenous Daratumumab, and certainly duration of administration is much longer in intravenous arm. Immunomodulatory agents can increase risk of venous thrombosis in patients with multiple myeloma. International Myeloma Working Group provides a guideline for VTE prophylaxis in patients undergoing immunomodulatory medication-based therapy. They divide risk factors into individual, multiple myeloma-related, as well as myeloma-related factors. I will say that patients who have orthopedic complications, fractures, immobility are at particularly high risk, patients with high volume of the disease, and those who are getting high-dose dexamethasone as well as multi-agent therapy are considered higher risk for blood clots. So if patients have no risk factors or just one individual or disease-related factor, International Myeloma Working Group recommends aspirin daily to prevent blood clots. For patients with more than 2 individual or disease-related factors or one therapy-related factor, therapeutic warfarin or low molecular weight heparin at a prophylactic dose is recommended. Now, could you use direct oral anticoagulants for prevention of DVT? Phase 2 study was published by a French group examining Apixaban in newly diagnosed multiple myeloma patients receiving treatment with melphalan, prednisone, and thalidomide, or in patients with relapsed multiple myeloma who received treatment with lenalidomide, dexamethasone. They showed that prophylactic dose of Apixaban was fairly effective in the first 6 months. There was one case of symptomatic DVT, and that was in a patient who had to have prophylaxis interrupted due to thrombocytopenia. There was one major bleeding and 10 clinically relevant non-major bleedings. So interesting findings. A lot of institutions have adopted use of oral anticoagulants and have published their experience in prevention of DVT in patients with multiple myeloma, but certainly larger studies would be needed to make it a standard of care. Selinexor is a first-in-class XPO1 inhibitor that was approved about a year ago for treatment of relapsed refractory multiple myeloma, and that brings new set of side effects to management of myeloma. Patients treated with selinexor are very likely to develop cytopenias, nausea. Some of them require more than one antiemetic, so this is by far the most emetogenic treatment for multiple myeloma. Patients should receive prophylaxis with ondansetron, and those who need additional antiemetics should receive olanzapine that crosses the CNS barrier and may be particularly effective in these patients. Patients who come down with nausea, vomiting, and diarrhea are more likely to develop fatigue and hyponatremia. So salt tablet supplementation may be needed in patients, or appetite stimulants as well as methylphenidate can be helpful in patients with cachexia and low appetite. Most of these side effects are going to occur within a week to 8 weeks in the first 2 months. And if patients are supported through effectively, they seem to alleviate over the time. With that, I would like to thank you for your attention and interest in updates on supportive care in multiple myeloma.